Good afternoon, class. My name is Joseph Lamond, and today I'm going to be talking to you about wrestling and specifically the injuries that commonly occur. So, factors that affect the rate of injury are one, weight cutting. It's a huge thing in wrestling. People are always trying to get down to lower weight classes, and so they lose weight very unhealthily, which causes dehydration, can affect bone density. Um, and overall, it's just they're malnutritioned, so it affects their energy levels and then their ability to protect themselves. So another thing that affects injury is slippery mats. After you're wrestling, it gets sweaty. You can slip, fall. Uh, your opponent's force, how much stronger they are than you, how they're wrenching your shoulders or elbows or legs, if they're slamming you. Um, Commonly, those are the factors that are most common for injury. So the injuries we're going to cover are dislocated shoulder, sprained ankle, and elbow tendonitis. So dislocated shoulder, this is long and a lot of words here, but basically it's when your humerus slips out of your glenoid fossa, whether it's anteriorly or posteriorly. Uh, so the mechanism of injury for an anterior dislocation uh, is basically when your arm is extended and stretched out behind you, and then you fall, or it's a force that's coming behind you, hitting, causing your humerus to move forward out of the glenoid fossa. For a posterior dislocation, it's the exact opposite. You're gonna have your arm internally rotated and closer to you, and could happen from an epileptic fit, electrocution. You could just get hit really hard in the shoulder and then pops out inferiorly. And with both these injuries, anytime the shoulder is dislocated, fracture is a high possibility. So, which we'll go into it next. So, the format I did my assessments is same way they would do it at a hospital or any type of medical facility, using a SOAP note or using the acronym OLD cards. So the subjective information we'd be getting, they'd be in extreme pain, 7 out of 10 or more. They heard a pop, and patient experiences weakness or inability to move arm from the pain. So what we're going to do, majority of the dislocations are anterior, and so most commonly be due to the arm being positioned in the excessive amount of abduction and external rotation, accompanied by, like we said, that blunt force. So our assessment is going to be based off of an anterior shoulder dislocation. And first thing we're going to do, send them to, other than the immediate care, if we can reset the shoulder, and if you're trained to do so, in my line of work, that's something I would be doing, especially in military medicine. I'm the only one there a lot of times. So I might not have the first two things, X-ray or MRI, or be able to refer. I'm going to have to reset it, and we're going to just have to get by. But for the sake of this class, we're going to refer to orthopedic specialists because over 50% of cases become chronic and require surgery. And we're going to rest, ice, elevate, compression, right? So the shoulder is not nearly as stable as the hip. It has a lot more range of motion, but it's kind of just held in there by a whole bunch of ligaments and tendons. So that's why shoulder injuries are so common. So assessment, one way we can assess it is with the empty can test. So it's like you're holding two cans, flip them upside down. Your arms would be extended out like a Y, and if they're able to do that, it's a good sign. If they're not, then and we're also going to be applying force downwards. Okay, if they're unable to do it, it's a sign of dislocated shoulder. So for the rehab, I love having my patients do a throwers 10. Basically, it's a series of 10 exercises in the shape of an asterisk, basically, and you can do it without weight and progress with weight. The dowel rod stretch, you do around the world, elbow behind the back, pull up, down, swing through. So for the throwers 10, you're going to do every other day times 4 weeks, and it's basically 10 of each exercise as well. And you're going to keep doing it until your shoulder's better and thereafter, because it's great rehab or prevention. So next injury we're going to talk about is a sprained ankle. Most common sprained ankle is going to be from an inversion, and the links on these slides too you can click on if you want to see a video and example of it. Ankle sprains may occur from inversion or eversion, but like I said, inversions are the most common. So the mechanism of injury is a combination of excessive inversion and patellofibular inversion. So that would be a lateral ankle sprain. So I'm not going to go over all of these, but these are common ankle sprains. All right. So the major thing with ankle sprains is grading them, seeing how severe. So grade 1 is a stretch and/or minor tear of a ligament without tear of the ligament without like laxity. So really not that bad. Obviously, we're going to treat our athletes well and not tell them to. But in the world of sprains, they're going to heal well and be able to continue exercise relatively soon. Grade 2 and 3, however, more severe. There's a tear of a ligament and laxity, so it's loose. And then grade 3 is a complete tear, and you're going to see a lot of edema with that, and discoloration, and most likely no load bearing, no weight bearing. So same thing, we're going to do the OPQ-RST for the subjective. So it's going to onset, they're going to hear a pop, weakness or ability to bear weight, like I just said. Movement is going to provoke the pain, it's going to make it worse. It's going to be a sharp and throbbing. It's going to be localized for the most part. They'll be able to pinpoint where it hurts, and the severity is depending on the grade, ranging from 3 to a 10. That's a pain scale, right? And then temporal factors, meaning characteristics, and time. We'll normally see, as an athletic trainer, see them within at least 30 minutes of it occurring. And then some objective data that you're going to see tenderness, palpation, edema, erythema, discoloration, limited range of motion, telltale signs basically of an ankle sprain, right? So we're going to assess them with the degree of ankle sprain they have, and then same thing, we're going to plan for an X-ray, MRI, rest ice, elevate, compression, the Rice principle, and we're going to, and very important, anytime you see a patient or a client or athlete, you have to educate them on preventative measures using braces and wraps, and that goes for the shoulder dislocation too, and we have to educate them on rehab. So the inversion sprains are most common, like I said, due to hyperextension or tearing of the ATF or the anterior talofibular ligament and or calcaneofibular ligament, the CFL. The test an athletic trainer can do is the tilt test or anterior drawer test. So here's the anatomy. We see the tibia, the medial ligament, and the CFL, and the ATL, right there. Okay. So for the tilt test, you can pause this video and read exactly how to do it. You're just really seeing the range of motion, and we're going to be turning exactly how the picture depicts. Then the anterior drawer test, we're going to be moving the heel forward and seeing the movement of it, seeing the movement of the foot and how loose it is. So for the rehab, we're going to do a plantar flexion, also known as calf raises, 2 to 4 sets, 10 reps. QD means every day for 4 weeks. And with all these rehab exercises, I highly recommend, if you have an injury, continue doing it even after it's healed. Use it as a prophylactic treatment or preventative treatment, right? The gastrocnemius towel stretch, stretching out the calf. You're going to wrap a towel around your foot and pull it towards you. You're going to do 2 sets of 40 reps um, for 4 weeks, and like I said, beyond. And when I say 40 reps, you can either do reps, working on mobility, moving it back and forth, or just holding it there. Toe towel grab, you're going to do 2 sets. So you're going to grab a towel with your toes. It's going to work on your tibialis anterior muscle, and it's going to work on strengthening the ankle joint as a whole. And then great range of mobility exercise for any type of ankle injury is to draw the alphabet with your foot and complete the alphabet every day. Wake up. It doesn't take very long. And like I said, great range of motion mobility exercise, and do that every day for 4 weeks and beyond. So last injury is going to be tendonitis of the elbow. So tendonitis is, excuse the misspelling there, is inflammation or irritation of the tendon. Any of the thick fibrous cords, I don't want to bore you and read through the whole thing. Basically, your tendons are inflamed and it hurts. It's pressing on the nerves. It's preventing your muscles from moving as smooth, your muscles or joints moving as smooth as it wants to. And common names are golfer's or tennis elbow. So mechanism of injury, this is a true, any tendonitis really is going to be an overuse injury. It's going to be overuse of the forearm, tricep, or bicep muscles, or a combination of all 3. And this is very true in wrestling. You're going to use all those for grabs. You're getting pulled. You're pulling other people, pushing them down. So for the SOAP note, the onset it's gradual over time. It's not necessarily going to happen at one moment. Like I said, overuse injury. Things that are going to make it worse are moving it and grabbing objects, gripping objects. It's going to be a sharp and throbbing pain. So it'll just throb, and then you move it, it's going to elicit a sharp pain. It's going to be generally localized, but pain may radiate upon the movement if nerve impingement occurs, meaning if the nerve is compressed down by any of the swelling. The severity during flare-up pain may range from 2 to 8, so it can be a wide range. Once again, symptoms usually have been experienced over a long duration before an athletic trainer even sees them. They're going to one day just be like, I'm tired of the pain, and they're going to come to you and say, fix me. So that's when we would have to go over the rehab. And we're going to see a tenderness palpation, edema, limited range of motion, weakness. It's going to be a 4 out of 5 on the strength test. And that we talked about the Yergason's test just last week, and that's something we would do. We could also do for this test. So for the plan, like I said, MRI. We're not worried about a broken bone here, so we don't necessarily need the X-ray. We're going to RICE, educate the patient on preventative measures such as braces and wraps. And educate them on the importance of proper warm-up, stretching, give examples such as using a PVC pipe before practice. So warming up with someone who, emphasizing warm-up, someone who has tendonitis is key. The looser it is, the more warmed up it is, the less trauma we're doing to that tendon. So a good warm-up is extremely important. So the extensor tendons and the lateral epicondyle. So we have the lateral epicondyle right there, okay? And these are the extensor tendons, and these are what's going to be inflamed, and that's going to cause a lot of discomfort. And then I said Yergason's test earlier. Excuse me, I meant Cosen's test. So for the Cosen's test, you're going to be manipulating right on the elbow and having them flex up, and it will elicit pain. So you're going to have them do 2 to 4 sets of the dowel rod stretch, 40 seconds every day before exercise competition. and I'm running out of time, so I appreciate it. Have a good day.